Hi, everybody. My name is Bonnie Draper. I am the Clinical Advisor with Essity Canada. I'd like to welcome you today to our session on antimicrobial resistance, stewardship, and wound care. Where are we in 2020? I am so excited and very honored to introduce to you Dr. Boyar. I did hear Dr. Boyar talk a few years ago, and it definitely had a lasting effect on me. So I know that you're going to enjoy this talk. Before I introduce Dr. Boyar, just a couple of housekeeping items. During the presentation, please input any questions that you have for Dr. Boyar into the question and answer box rather than the chat box. I will collate the questions and pose as many as I can to Dr. Boyar at the end of the session. Dr. Vita Boyar is an assistant professor of pediatrics at Zucker School of Medicine at Hofstra Northwell. She is a neonatologist and a certified wound specialist physician practicing both neonatology and wound care at Cohen's Children's Medical Center of New York, Northwell Health System. Dr. Boyar is the only wound certified neonatologist in the US and developed the Northwell Neonatal Wound Service, which is the only one of its kind in the area. Dr. Boyar is a board member of International Society of Pediatric Wound Care. She has traveled both nationally and internationally, teaching on advancements of neonatal and pediatric wound care. Her work with neonates and wound products has been featured in Good Morning America, published in various journals, and has received awards and honors. Dr. Boyar is a creator and author of monthly pediatric column at Wound Management and Prevention Journal called Children with Wounds, Asking the Right Questions. Dr. Boyar is also a member of Society for Pediatric Research. Her research interests include antimicrobial products in the neonatal population, skin maturation, point of care ultrasound as the techniques to assess intravenous extravasation, as well as novel methods to prevent and treat skin injuries. Her quality improvement projects have focused on pressure injury prevention. Dr. Boyar leads the pressure injury prevention group at the Cohen Children's Hospital as part of Nationwide Children's Hospital for Safety Initiative. She also serves as co-chair of the Northwell Pressure Ulcer Task Force. She is a reviewer of various journals, including Wounds, Journal of Parentology, Journal of Dermatology, Journal of Wound Ostomy and Continence Nursing, Pediatric Dermatology, and Wound Journal of Dermatological Therapy. Dr. Boyar, thank you so much for joining us. I'm going to shut my camera off now.
Thank you for that wonderful introduction, Bonnie. It's very kind of you. And to the organizers of Wounds Canada, thank you very much for the invitation. I'm very excited to be here this afternoon with you and talk about this really important topic. This topic that we will be talking about is very relevant today and will be just as relevant tomorrow and a few years from now. And so our topic of discussion is antimicrobial resistance, antimicrobial stewardship, and wound care. Where are we in 2020? This presentation is sponsored by Essity, North America, but the content and the opinions of this presentation are just mine. Before we dive really deep in the presentation, I want to give you a story. A 5-year-old boy is walking around in a zoo with his dad and sees a 100,000 pounds elephant. And the elephant has a chain on his leg that is connected to a tree. And the boy says to his dad, "Dad, don't you think if an elephant just pulls his leg, he'll break the chain and he can go free?" And Dad says, "Yes, I think so." But the elephant has learned not to do so. When he was a child and the chain was on him, he was taught that every time he would pull on this chain, nothing would happen. And over time, the elephant learned that it is what it is. And he stopped trying, and he stopped challenging. And now he's just doing what he's used to. The moral of the story is there's a little bit of that elephant in all of us. The way we are practicing now is what we have learned in a very long time. We have been taught that antibiotics are very strong, they're very successful, and that often antibiotics are to be started early and to be given freely because they will prevent potential worsening of the infection. And this is how we challenge, and this is how we practice. The consumer or our patients have learned that antibiotics are the answer to everything. And even if you have a regular cold, and even if a child has an earache that is virally caused, the consumer will often ask us for antibiotics. So I challenge you today that after you leave this talk, we stop practicing like these elephants and we start challenging ourselves. And we start considering that maybe our practice needs to open up to new possibilities. And maybe just because we learned something over many decades or over many years ago, maybe, just maybe, we can change the way we practice. But before we talk about the present and the future, let's talk about the past. One of the greatest discoveries that our world has seen is discovery of antibiotics. And it's interesting, this was a discovery by accident. Alexander Fleming was a very smart and wise man, but he just happened to be on vacation, and in vacation house he had a lab, and he was playing with his petri dishes. And the thought is the way he discovered penicillin is through a fungal spore landing on his petri dish. At that time, he wasn't able to isolate the substance, yet he called it penicillin. And about 10 years later, Chain and Florey were able to manage to produce a larger amount of penicillin. But the initial discovery goes to Dr. Fleming, who received Nobel Prize in 1945 for this discovery. He was a very smart and a very wise man, and he recognized that overabuse of this substance can actually lead us to the pre-antibiotic era. And what he said during his Nobel Prize acceptance speech, he said, "An ignorant man may underdose himself, make them resistant, rendering penicillin ineffective in the future." Well, so here we are, many years later. And what we know is that if we continue to use the same amount of antibiotics that we do today, by year 2050, the numbers of antimicrobial resistance will be astonishing. Today, it's not so bad, but about 700,000 people die every year from infections that are resistant to antibiotic. 700,000. About 50,000 in Europe, about 50,000 in North America per year. But if we continue with the same number of antibiotics that we prescribed, by year 2050, in just 30 years, this will be #1 cause of death. As many as 10 million people will die due to the antibiotics' inability to cure our infections. Many agencies every year have warned the public of what a tremendous effect the antibiotic resistance will play on the global arena, in the health arena, in the socioeconomic development, poverty. So the significance of this finding or antimicrobial resistance is much beyond a singular country. It's a very global phenomenon. But we don't have to speak about global, and we don't have to speak multiple countries. We can talk about here, next to us, and something that rings back home. Right now, if you're practicing on the regular floors, you have patients that come to you with pneumonia, and many of the Streptococcus pneumonia are now resistant to penicillin. Tuberculosis, again, this is widespread around the world. And many of the Mycobacteria tuberculosis species are now resistant to things like rifampin and INH. But again, we don't have to go far. I will share a story with you of my own practice. So as Bonnie said, I'm a neonatologist. I work in a neonatal intensive care unit. I take care of the tiniest of the babies that weigh 500 grams, or the sickest of the newborns that may be born with congenital heart disease and congenital abnormalities of other organs. As a wound-certified physician, I go around various pediatric floors, and I take care of patients in the pediatric intensive care, patients on the hematology oncology floor, which are maybe recovering from a cancerous condition. So not that long ago, in my own neonatal unit, we had an outbreak of methicillin-resistant Staph aureus. This is one of the biggest fears of any neonatology practitioner. colonization of our preterm neonates with either MRSA or MSSA, the morbidity and the mortality of our preterm or sick full-term babies from these microorganisms is tremendous. And what happened when we found out is that about 30 to 45% of our MRSA isolates were Mutarisin resistant. They came from communities, so every community is different. Many of the strains are not resistant to the current antimicrobials, but some are. When we had our babies who would be colonized by the MRSA or MSSA, we would use Mutarisin to decolonize the babies. But then we realized that they would still have colonization weeks and weeks out. About, again, 30 to 45% of them were resistant. This was a very costly enterprise. We truly had to change what we do outside of our NICU, how we practice in the NICU in order to eradicate this. And it took many, many months. So I'm very familiar with how antimicrobial resistance affects each and every one of us every day. But how do these microorganisms develop this resistance? It's very interesting. Resistance existed long before antibiotics were developed. Natural resistance comes from environment, it comes from the soil, it comes from the exchange, so the quorum talking by the bacteria, through the chromosomal genetic support, and this natural resistance affects all antimicrobial species. Acquired resistance is mostly acquired through various mutations. It's transmitted through chromosomic support, through plasmidic support, through transport genetic support, and it doesn't affect every strain. It affects a fraction of strain. And we know that the acquired resistance have been increasing due to antibiotic use. We also know that some population of microorganisms have increased predilection to acquired resistance, and if they are in near proximity to the other population of antimicrobials, they will share this acquired resistance and become even more virulent. So there's a variety of ways how antimicrobial organisms, how bacteria, viruses, and fungi have learned to evade antimicrobial agents. But how do antibiotics work in general? We know that right now we have about 25 common antibiotics that is available to our practicing arsenal, and they work different ways. This is a complex slide, but just to point a few things, many antibiotics work on cell wall synthesis, such as vancomycin, such as bacitracin, such as penicillin. They cause lysis of the cell wall and leakage of the microbial content. Other common antibiotics, such as gentamicin, work on protein synthesis. Mutarisin, as I mentioned before, also works on protein synthesis, and so forth. So obviously it makes sense for the microbes to work on one or the other of the targets where antibiotics work. So we know that there are various mechanisms of resistance, some of them by preventing antibiotics from reaching its target, such as impaired cell membrane permeability, or they put special efflux channels through which they basically push out the antibiotics component out of their cells. They also put supplementary targets that give antibiotics a false track, or they may decrease the affinity of their targets to these antibiotics. So as an example would be our penicillin and cephalosporins, such as the beta-lactamase cleavage on the beta-lactams, or sulfa drugs that are able to have this efflux phenomena and actively export the antibiotics out of the cells. I have to say, the microorganisms, the bacteria are very creative when it comes to being able to get rid of the antibiotics efficacy. But along that, what is important is how creative are we? Are we able to catch up with the microbial resistance? Well, take a look here. So the reds are antibiotics, the greens are vaccines that are available right now to the human beings. The star is when the drug or the vaccines were created, and the black X is when the first studies of antimicrobial resistance have been reported. So something really important I'd like to point out here. Every single antibiotic that at the moment available to us is or have had some resistance within certain bacteria. Even the more synthetic ones, even the newer agents, have also been shown to have resistance. What's even more concerning to me is if you look, some of the newer antibiotics such as daptomycin, linezolid, levofloxacin, the times that have expired between the beginning of the antibiotic use to the time that microorganisms have become resistant is very short, and it's getting shorter and shorter by the years. The interesting point is that we really haven't come up with any new classes of antibiotics since about 2005. So as bacteria is ahead of us and is figuring out a way to become resistant to the antibiotics, we have not been able to come up with totally new class of antibiotics. It's been 15 years and we have done some variations, but we really are in need of a completely new class of antimicrobial product to hopefully, again, get an upper hand on the bacterial resistance. Why are we talking about antimicrobial resistance? What are the drivers of antimicrobial resistance and what impact do they have on us? I think before we talk about impact, let's talk about drivers. As I said before, antimicrobial resistance existed in the soil, in the environment, even before antibiotics came to fruition. That existence in the soil and the environment often translates into food that we are consuming, into animals consuming this food, and then us potentially consuming this through the animal product. But also, I think we as humans are a big factor why the antimicrobial resistance have developed. And I alluded to that earlier. The misuse was the overuse of the antimicrobials. But also, maybe not so much around Canada or United States, but poor access to the quality, affordable medicine, to the basic hygiene, to the ability to wash hands effectively. And I think today, more than any other times, we understand how important the clean water, the sanitation, the personal hygiene, the important infection practices are around the world. COVID-19 is teaching us this all over again. But COVID-19 is novel and new. Antimicrobial resistance has now been existed for a few decades and will continue to exist, but hopefully COVID-19 slows down. In 2019, Department of Health have identified 7 priority areas for action to decrease antimicrobial resistance. And it has been releasing their priority actions every year since then, and they're very similar. And some of them are to improve infection prevention, to improve control practices through implementation of the best practices. We need to optimize our prescribing practice through antimicrobial stewardship programs. We need to understand when we need to prescribe and when we can hold off on prescribing systemic antibiotics or topical antimicrobials. And as I said before, we need to develop new drugs and new treatments. And we need to have better access to surveillance data so we know what's happening around the world. And we need to have a priority of antimicrobial stewardship in our research. And I can tell you that in my institution, we talk about antimicrobial stewardship every day. A lot of our guidelines in the neonatal ICU have to do with antimicrobial stewardship. How can we minimize antibiotics? How can we minimize the wide spectrum antibiotics? So this actually exists in my daily conversation with parents, with trainees. But so what is antimicrobial stewardship, first of all? It's defined as an interprofessional effort across the continuum in the patient care that involves the timely and optimal selection of the antimicrobial agents, their doses, and the duration of their use. And the aim is to achieve the best clinical outcome with minimal toxicity to the patient and to the environment. Very, very important. So I think many people think about antimicrobial stewardship when we talk about systemic antibiotics. But here we are in the wound conference. So is there a problem with antimicrobial resistance and the need for antimicrobial stewardship in wound healing? And the answer is yes, definitely. I think now more than ever, the technology has allowed us to treat conditions that we would not have treated before. Many of these conditions lead to surgical wounds that potentially can be hissed. Even an example of my neonates, some of the babies that survive now wouldn't have survived before, and they survive through the help of this technology. But this technology may induce injuries to their skin. For example, equipment that causes pressure injuries. And so more and more wounds are appearing, and therefore more and more wounds need to be addressed through the antimicrobial stewardship. So what are the key factors that contribute to the antimicrobial misuse in patients with wounds? And they're very similar as around the medical care in general. First of all, diagnostic uncertainty. Is there a bacterial infection? Is it a topical infection? Is it just colonization? Or is it a more systemic infection? How do we figure it out clearly? We'll talk about it in just a moment. Clinician ignorance. I think that's very important. We all have a little bit of that clinician ignorance within us. We often use our naked eye as our way to diagnose infections, especially wound infections, and I don't know that our naked eye is the best way. And even doing a regular skin culture where our wounds are is not very sensitive either. And so sometimes we just sort of guess and we treat based on our best guess, but it isn't always the most sensitive way. And then clinician fear. I think that's real and that's important. We are often afraid that we may not treat properly, or we may fail if we don't treat as aggressively as some of our other colleagues, or we are afraid of having a bad outcome. And so just in case, we will add an antimicrobial, whether it's a systemic or a topical. And patient demands. I think this is a really, really important factor. The consumer is educated these days, but it's often not educated enough. But the consumer often feels that antimicrobial solve all the problems. And so even you as a physician trying to stay away and not to give it all the time, the pressure from the consumer on the clinician is definitely great. So I alluded to the difficulty of figuring out what type of bacterial involvement with the host do we have when the patient presents to us. And we know that bacteria on the skin exist in continuum, starting with contamination, progressing to colonization, and then critical colonization, and eventually potentially leading to systemic infection. So healing and figuring out how to heal this bacteria sometimes is challenging. And we know that the way we prepare all the wounds is often based on an acronym TIME or DIME, where you have to debride the wound bed. This is, I think, the most important step in any wound bed preparation. Debridement, whether it's mechanical debridement, sharp debridement, enzymatic or autolytic, is the most important step in the success of initial wound healing. But after that, you have to address infection, whether if you have an infection, you have to treat that infection, or you have to prevent infection and decrease the inflammation. And of course, we have to pay attention to moisture balance and age viability as well. We often say that wound bed preparation is often biofilm based. Well, what does it mean for us? We know that about 6 to 10% of acute wounds have biofilm on their wound bed surface, and about 90% of chronic wounds have biofilm as well. What is biofilm? Biofilm is a community of bacteria that have evolved over time and found a way to protect themselves from the antimicrobial, from the antimicrobial medicine, I guess, or from the antibiotics. So planktonic bacteria is different. Planktonic bacteria are much easier killed by systemic antibiotic. But bacteria that is in biofilm is encapsulated by a polysaccharide capsule. It's a very sticky capsule that is not easily penetrable by our systemic or topical antibiotics at times. Also, the substance is very inflammatory to the host, and also the substance is very protective to the bacteria that lives within the substance. We know that it's often a polymicrobial community, and we know that through the quorum sensing, the bacteria is able to communicate with each other, is able to exchange gene information, is able to exchange nutrients, and is able to invite more bacteria to the biofilm. And so one of the most important points is how can we eradicate the biofilm? Do we need to use systemic antibiotics? Do we need to use topical antimicrobial? Well, from what the literature have shown to us, is systemic antibiotics are really not very helpful in a biofilm-based wound care. We know that in order for antibiotics to kill the bacteria, bacteria has to be metabolically active. And it is often not so in the biofilm, in an extrapolymeric substance. It is often quiescent, and therefore systemic antibiotics don't work as well. Also, we often know that bacteria inside the biofilm may very well be below the wound surface, and the penetration may not be the greatest. And that's actually an issue with a certain topical antiseptics and antimicrobials as well. But how do we decide? Are we going to use a topical product, or are we going to use a systemic treatment? We know that some people use mnemonics to sort of remember how to differentiate between the two. NERD is one such, and it stands for non-healing wound, exudate, red granulation tissue, debris, and smell. We know that if 3 out of 5 of NERD's constituents are present, you have about 70% chance of this being a topical infection, and you can try and use topical treatment and be successful. Whereas as you progress in your symptoms towards stonies, with increase in wound size, increase in temperature, new wound breakdown, increased exudate, or increased edema, you probably will lean more towards systemic treatment. So why consider topical therapy? We mentioned some of the advantages in the past slides, but I think it's important to understand that in a biofilm-based wound care, topical antimicrobial therapy will offer higher and sustained concentration of the antimicrobial at the site where you want it to be. Therefore, you will have less systemic absorption and less systemic toxicity, and hopefully limited amount of the antimicrobials that will be needed to use to decrease that infection. Also, it may avoid unnecessary systemic reaction that the host will produce in response to given systemic antibiotics. And I think it will direct attention of both the patient and the provider to the wound as opposed to overall systemic toxicity. There's definitely disadvantages as well. And some of the disadvantages is that there's few agents that have been proven totally effective in clinical trials. And again, depending on the populations that you're working with, many of these agents have potential toxicity, also have limited or unlimited systemic absorption, and also can cause local effects, whether it's an allergic reaction or whether it causes a delayed wound healing as well. How do we choose the right antimicrobial agent, topical antimicrobial agent? Well, first of all, to talk about definition. We know that disinfectants are agents with activity against virtually all disease-causing microorganisms, including spores. They can be toxic to the newly grown tissue, and therefore they're used primarily from sterilizing surfaces. Most topical antimicrobials are divided into two groups, antiseptics and antibiotics. Antiseptics are disinfectants that can be used on intact skin or on surfaces. They are able to kill or inhibit microorganisms. They often have multiple microbial targets and often have very broad antimicrobial spectrum and residual anti-infective activity, but they can be toxic to a variety of cells, fibroblasts, keratinocytes, leukocytes, and therefore slow down the wound healing. Antibiotics are either naturally produced chemicals or synthetic chemicals. They usually have a very specific cell target, and we talked about some of these targets a few slides prior. They have a narrow spectrum of activity and relatively non-toxic. But again, relatively, I think, is the most important word here, depending on the population that you're working with. If you are in my shoes and you're working with neonates, just about everything is toxic to this population. So there are many different antiseptic and antimicrobial products that are available in our repertoire. Some older ones, such as hexachlorophone or acetic acid, are not really being used anymore right now. So hexachlorophone is actually an interesting story. In the neonatal world, it was being used years ago as chlorhexidine is being used right now to decrease MRSA or MSSA colonization. And then we realized that some of these babies have died and had encephalopathy. And upon autopsies, it was discovered that hexachlorophone was the cause of that. So I think lessons learned, we are now, again, in the neonatal world, are quite cautious about using chlorhexidine. Similar story, it's a wonderful topical antimicrobial. It's long-acting. It works on gram-positive and on gram-negative. It's used often in many adults who undergo through surgery. It's also used in pediatrics to decolonize the skin prior to surgeries, and it's often used as an antiseptic in younger children as well. But what we also know is it does have systemic absorption, and in studies in animals and in lab studies, it can be toxic to certain cell lines, such as osteoblasts, oligodendrocytes, chondrocytes, and so we don't know what is the threshold when specific absorption become a toxicity and a real problem. And so in neonatology, for instance, we don't use it on babies less than 2 months old or less than 1,500 grams. And I think we really need to learn more about this particular antiseptic in regards to some of our population. Iodine-based products. So we know that this is a very old antimicrobial or antiseptic. It has been used over 150 years. We know it works very well. It works through a variety of mechanisms. It can lyse microorganisms by causing breaks in the cell membrane, by causing the leakage of organelles, as well as working on the nuclear component and protein components. We know it comes in a variety of different preparation. The iodophores release free iodines, and then there's the cadexomer iodine that is less toxic. But the concern, again, with a specific population of its toxicity. So neonates, breastfeeding moms, people who may be immunocompromised after a chemotherapy. We know that it can affect thyroid concentration significantly and cause hypothyroidism. So we don't use this as a topical antimicrobial wound care in pediatrics. We use it as an antiseptic when we put central line. But being that we are aware of the toxicity, we always try and remove the product once the procedure is done. Silver products, I think I could give an hour talk about silver. It's one of the oldest antimicrobials. It's used in many different preparations as a lotion, as infused in a variety of foams, nano silver. We know that silver is excellent. It works for both gram-positive and gram-negative antimicrobials. We know that in order to be successful at its antimicrobial action, it needs to have a sustained contact with the organisms, which sometimes can be challenging if you have something like, say, like silver sulfidizing. It needs frequent reapplication. And so more and more practitioners are using sustained release silver preparation. So silver is challenging in certain populations as well. The way it works is very similar to betadine and iodine components. It works through cell membrane damage. It works through protein inhibition. And we know that basically it kills the bacteria, therefore potentially having a reaction from the host to the inflammatory components of the bacterial cell death products. We also know that silver has a potential to be toxic. So we don't use silver very much in my practice. In neonatology, pretty much not at all. With maybe with an exception of one condition that I'll tell you about in a few minutes. It is used in pediatrics, but we have to be vigilant about how long we use it for. We try not to use it for more than 10 days to about 2 weeks. Patients who have kidney problems can have toxicity from silver. It can have liver toxicity. It can have electrolyte abnormalities. It can cause leukopenia. It can cause argyria. So again, depending with which population you're working, this is not necessarily an ideal topical antimicrobial either. A common topical antimicrobial that is used all over the world is Mutarisin. And again, I told you we use it in our NICU as well. It works really well toward gram-positives, not as much toward gram-negatives. It's used to decolonize patients who are colonized with things like MRSA quite often. But again, it can actually cause some local irritation, some burning, and we now know that about 30% of isolates of very strong bacteria is resistant. The same can be said, by the way, about silver. That's one of the really important concerns in antimicrobial resistance in wound care. Many papers have described very strong virulent bacteria such as VRE, such as Pseudomonas, such as Klebsiella, no longer being sensitive to silver as a topical antimicrobial agent. And that's a very scary outlook because that's a workhorse, I think, in armamentarium, a very good practitioner, especially in the adult population. Other topical antibiotics such as Mutarisin or polymyxin, we really don't use it very much in my practice in pediatrics. Again, we know about 15% of the population is allergic to this product, and I think from the Cochrane perspective, it doesn't have the strongest evidence that it actually is very useful. So I think, you know, I'm giving you this talk from a perspective of somebody who practices in a very specific population, neonatal and pediatric population, and most of the data that is out there is, of course, in the adult trial. And I suspect that majority of you who are listening to me today are actually adult practitioners. And I think you have wonderful choices what can be done. In addition to silver, in addition to iodine, there are other products, and there are many papers that have talked about how successful these products are in eradicating infection and prevention of the infection. So we now know that there's enough randomized controlled trials and actually Cochrane reviews on most of the topical antimicrobials. I will try and summarize each of them very quickly. So products on iodines have been described, and the Cochrane review does suggest that there's evidence that it has superior efficacy compared to placebo. It works very well on venous leg ulcers, on diabetic-related pressure injuries, on chronic wounds, and so it does what it's supposed to do. It's an excellent topical antimicrobial. And I think we just have to know that the potential toxicities exist. And in certain populations, such as neonates, this may not be the wisest choice of a topical antimicrobial. I think the same goes for silver. Again, there are many, many studies that have described silver and its efficacy and the fact that it's an excellent and very efficacious antimicrobial toward both gram-negative and gram-positive. Again, the toxicities are there. And on the other hand, some other papers have compared this to placebo in certain type of wounds and have sort of had an equivocal response. But at this point, I think the Cochrane recommends using it cautiously, especially in some population, and being aware that the silver resistance is becoming more and more prevalent, and specifically in quite strong and virulent organisms, such as a variety of gram-negatives. There's been a lot of papers that have described silver resistance, and I think this is a perfect opportunity to talk about antimicrobial stewardship, because so many silver preparation exists and it's commonly prescribed and it's cheap, such as silver sulfadiazine. But we do have to stand back, read the literature, and recognize that maybe we need to slow down. Other agents that are maybe not as commonly used as, let's say, silver or iodine products, but are just as effective from the antimicrobial component perspective, are mixtures of methylene blue and gentian violet. Those are two dyes, organic dyes, that have been used quite a long time in medicine. Gentian violet has been used for years to treat thrush in neonates, and so it would be given as a solution to paint inside of the baby's cheeks. We know it's non-toxic. Methylene blue has been used for a variety of medical reasons, such as hypertension in adult world. And if bound to a variety of foams, they work very well as a topical antimicrobial. We know that the way the mechanism of work is that when it comes to the contact with the exudate and bacteria, they are positively charged dyes. And so they work really well with the negatively charged bacteria, and they cause a break in the oxidation reduction chain or electron transport chain. Basically, they make bacteria hypoxic. And so that's how they kill the bacteria. In order for them to be effective at it, the foam has to come in contact with the exudate. I personally use this product in my practice in the neonates as well as in pediatrics. We know that it's not absorbed from the foam. And we know that the foams that it often comes in have interesting properties of weaken and almost negative pressure-like pulling ability, which helps with the exudate. So again, the Cochrane review have looked at some of the studies and have determined that it provides some autolytic debridement and it provides antimicrobial coverage as well. Polyhexamethylene biguanide, a relative of chlorhexidine, but a safer relative than chlorhexidine. We know that chlorhexidine is broken down into these metabolites that in enough concentration are concerned for this toxicity. Does not seem to be the case with PHMB. PHMB is positively charged by guanide, so it works really well with the gram-negative. So it's an excellent product to use on people who have venous insufficiency, diabetic foot ulcers, any kind of injuries that are more predilection for gram-negative bacteria. And it works as an antimicrobial agent through binding to the gram-negative bacteria, lysing the membranes and causing the leakage of the organelles on the inside of the bacteria. The studies are out there. They have seen this as a fairly safe and not really toxic antimicrobial. But again, in my practice, for instance, there's really no studies that show how it's been used in pediatric population. And as pediatric practitioners, we are very cautious about using something on a big scale when data is not available. Honey, I think it's something I have to mention. Honey has been used since antiquity and probably one of the oldest topical antimicrobials, although we often don't think about it that way. This is, of course, medical grade honey, the honey that is irradiated, so there is no spores in the solution. And the way honey works is by being hyperosmolar and increasing lymph flow and helping with the autolytic debridement. It also has a very acidic component, therefore it prevents bacterial colonization. But as far as an antimicrobial component, it works two ways. Honey has hydrogen peroxide generation when it comes into contact with the exudate, and it has methyl glycolate, which is something that bacteria puts into honey during its preparation, which works by killing both gram-negative and gram-positive bacteria. We know that to this day, there is no bacteria resistance to honey that is known, which is a wonderful component, very important. And we know that it's natural, and unless you're allergic to honey, there's no other toxicities. So honey is a workhorse of antimicrobial product in my practice, and parents are always very happy when they hear that I'm using a natural product. And it works really well on just about any wound, really. You can use it on fist wounds, pressure injuries, diabetic pressure injuries, extravasation in the babies, things like that. So I have spoken about many different types of antimicrobials, and I think what they all have in common is that by different mechanisms, but they all cause bacterial cell death. When bacteria dies, byproducts of bacteria are released, whether locally or systemically, and they can induce an inflammatory reaction from the host. So sometimes if you are a healthy, 23-year-old adult, that's perfectly fine. But if you are a 500-gram, 23-week-old neonate, this type of population doesn't have an ability to reduce the oxygen radicals and the inflammatory mediators that are being flushed throughout the body. If you're a patient who is battling cancer, that's a very similar story. If you are a elderly individual who doesn't have the best nutrition state, that's a similar story. And so I think we need to switch gears and talk about another type of antimicrobial product, topical antimicrobial product, that is different in the way it works. We're going to talk about hydrophobic technology next. Hydrophobic technology is important because the way it gets rid of the bacteria is not by killing the bacteria, but by allowing the bacteria to bind to the dressing and safely removing it from the wound. So what is hydrophobic technology? Dialkyl carbamyl chloride is a hydrophobic, which means water repellent fatty acid derivative. It is bound to different type of synthetic mesh or cotton mesh or different substance that can then be used as a dressing on a wound. Very important for us to understand that pathogenic bacteria express cell surface hydrophobicity. All of the pathogenic bacteria. They needed cell-to-cell communication in their DNA exchange. This is how they developed their resistance. They needed to bind to molecules for nutrition. They needed to bind to surfaces to rest. And that's how they adhere to host tissue. They also needed for protection against phagocytosis by a natural host. And so hydrophobic technology utilizes these principles. And basically what happens is bacteria and fungi are inactivated once they bound to the dressing, and then they are prevented from proliferating or from releasing harmful toxins such as exotoxins. The microorganisms are removed from the wound bed along with the dressing, and therefore they reduce the bacterial load. During this process, there is no cell wall disruption, there is no bacterial cell death, there is no systemic inflammatory reaction. Many studies have shown that all types of bacteria, gram-negative bacteria, gram-positive bacteria, anaerobic bacteria, fungi, possess hydrophobic interactions and therefore bind to the hydrophobic surface if allowed to do so. So the hydrophobic dressing is coated with dialkyl carbamyl chloride. It's a natural substance. It's actually produced by our bodies as well. It's actually produced in nature. So if it rains and you see a spider on the spider web, you see the little drops of rain beading on a spider web. And the reason for that is because it's actually naturally coated with a substance like dialkyl carbamyl chloride, which is hydrophobic. Studies have shown that within seconds of bacterial adherence to this hydrophobic dressing, they bind and they stay adherent. Within 2 hours, millions of the bacteria is bound, and it can stay bound for days. This product can remain on the wound for anywhere 3 to 7 days, depends how often you want to change the dressing, but the bacteria stays bound. Not only that, once it's bind to the hydrophobic surface, it becomes inactivated. The metabolism slows down, they take a rest, they no longer replicate, and therefore they no longer form the bacterial toxins. So in my mind, this is a really, really important point. Again, I work with population that is really immunocompromised, that is really weak, that doesn't have a lot of oxygen radicals, that doesn't have a lot of way to fight inflammatory mediators. So not having a product that induces that reaction is really important to my practice. Well, how effective is it? Is there literature? Absolutely. We know that DAC-coated products are effective against superbugs such as MRSA, VRE, Pseudomonas, Klebsiella. We know that it's effective in a variety of wounds, whether it's different pediatric wounds, whether it's surgical wounds, whether it's venous leg ulcers or pressure injuries. This is just an example of the table in the middle that have summarized a variety of different papers that have described the efficacy of hydrophobic interactions and bacterial removal and infection eradication. What also is interesting is that we found along the way that this dressing helped proliferation of the cultured fibroblasts and actually lead to a faster wound healing. So it's interesting because we know that products that are silver-based, even though they are very effective antimicrobial products, they are actually cytotoxic, and therefore they slow down the speed with which wounds heal. Whereas products that are DAC-coated products actually enhance the speed with which wounds heal. We know that this is a very safe product to use in pediatric population in a variety of different settings, including as just a routine prophylactic care against things like MSSA colonization. The study in the middle have compared right here chlorhexidine washing with just placing this green mesh on top of the skin and looking at the rate of MSSA colonization, and they both were equivalently successful. We know that there are certain pediatric congenital conditions such as ichthyosis or epidermolysis bullosa that have utilized this product safely, and I'll show you some of my cases in just a moment, which is really important because those are very fragile kids and very, very fragile skin. So there are studies that have compared DAC technology with other antimicrobial agents. Silver is an example, and silver in a variety of different preparations. And while both are fairly successful in their antimicrobial coverage, DAC technology is more successful in speeding up the number of days necessary for complete wound closure. We also know that while products that, let's say, silver-based, have developed resistance. There is no known resistance of any microorganism at this moment to hydrophobic technology, which is a really important point as we are talking about antimicrobial stewardship. It's available in a variety of different preparations. It's available as a surgical dressing. It's available as a super absorber if you are dealing with the venous leg ulcers, with the arterial insufficiency ulcers, with diabetic foot ulcers. And it's available as a contact layer. So the pictures that I'm about to show you in the next few minutes are pediatric pictures, not adult. And so this is an example of a dehiscestroschesis, which is an illness where intestines are outside of the cavity. And when it's closed, you can have slough on top of the wound if it dehisces. And we often use DAC-coated products to decolonize the skin to reduce the infection. Here's the next one. This is a child who had hemorrhagic blistering dactylitis and super infected with gram-positive bacteria along with very painful areas. And when she came to us, it was very difficult to do anything because she was so afraid of a painful interaction. And one of the things that people comment on with the DAC-coated dressing is that it kind of takes the pain away and it doesn't stick to the skin compared to other preparations such as regular gauze. Any of the dehisced wounds, sternal wounds, abdominal wounds, it's an excellent packing project. You can use it under negative pressure wound therapy. This is a giant omphalocele. This is another congenital pediatric condition where you have a baby that is born with the intestine outside of the cavity, but then as it epithelializes slowly over months, it can break, it can become colonized, it can become infected, and using DAC-coated products is an excellent way to counteract that condition as well. It can be used as a packing product during cellulitis. This is somebody actually who was battling cancer and really needed to go home. And we use this as a packing robe and as an outside dressing as well. As you can see, within 2 days, her granulation tissue was nice and clean and edema and erythema was subsiding. This is another example as a packing robe in a dog bite, infected abscess. This is an example of using it on this congenital skin conditions such as ichthyosis or epidermolysis bullosa, very difficult to treat and very challenging conditions. Here you have hyperkeratosis, and while this membrane is being shed, you have these deep, painful fissures, and these kids tend to have colonization of the skin by a variety of bacteria. So placing a contact layer that is both hydrogel infused and DAC-coated promotes moisture, but also allows to have antimicrobial coverage. This is the only antimicrobial topical agent, I guess, that safely allows you to be used for prevention. So if you have a high-risk incision, placing a hydrophobic coated dressing underneath the secondary dressing will promote skin sterility. This is an example where we used it as prevention in children who had amputation, and we wanted to make sure that it heals very well. And this is an amniotic band syndrome, where in utero, very tight amniotic band broke through the skin and the bone. And so the goals then would be for the bone to heal and later on to deal with the facial defect. And so we used hydrophobic product to make sure that this area doesn't get infected. And so DAC is very important in the way that it promotes lack of antimicrobial resistance. There is no systemic absorption, there is no cell debris. Therefore, there is decreased potential for systemic reactions to the exotoxin release and a natural healing environment. And in my closing, I just want to say that there's multiple key opportunities for antimicrobial stewardship in wound management. We have to be vigilant, and we have to step back and see other products that can be used, or can we use fewer products, and see if we can contribute to the positive antimicrobial stewardship. With that, I'm going to say thank you, and we have a few minutes for questions.
Hi, Dr. Boyar. We do have a few questions that I'm going to read out to you here. The first one is from Stephanie, and she has asked, how did you keep the skin moist enough for the, I'm going to say this incorrectly, ichthyosis baby, the baby. How did you keep ichthyosis, I apologize.
That's okay. How did we keep the skin moist enough? Yes, so the mainstay of these babies is actually using emollients, but the areas where these babies have deep fissures and areas where you're concerned for infection, I actually used hydrogel impregnated contact DAC coated product. And so not only keeps it moist, but it also gives antimicrobial coverage. All the other areas you can use Vaseline-based gauze.
Okay. Another question here from Jolene. Can Sorbact be used as a contact layer for negative pressure?
Absolutely, wonderful question. I use it all the time, and I showed you one picture where there was a 12-year-old child who had dehiscence of the abdominal wound. We pack it in, and it provides two purposes. It's an excellent packing agent. The granulation tissue actually does not seem to grow into this product, but it also allows antimicrobial resistance. So yes, all the time.
Okay. And this is from Teresa. What sign and symptoms would indicate that a person has silver or iodine toxicity? I rarely face some challenges with some patients who will insist that silver or iodine is the only type of dressing that works for their wound and has shown progress. However, the cytotoxicity is my concern.
Yes, I totally agree with you, Teresa. It's really difficult to know if it's happening unless you're determined to check. So if you are in my shoes and you are in the neonatal unit, you can actually check thyroid levels and see if somebody has been exposed to iodine, if it's becoming toxic, or if you see goiter development in an older patient that has been using this for a long time. Silver can affect electrolytes, can affect kidney, and can affect liver. So if you have capability of checking the electrolytes and laboratory numbers, then you would know. But other than that, I think that's our biggest challenge is it can take a long time before the toxicity develops and we wouldn't know. So you just have to know and think about it and explain it to the patient.
Okay, and I'm going to keep asking a couple more questions until I'm not sure what our timeline is to stop it, but there's a few here. In a situation where betadine is wide available in many hospitals and long-term care, and many healthcare providers use it widely on wounds, not only as antimicrobial but for treatment, what do you suggest to approach and address this situation and change this practice?
I think you have to know what your population is. So if you have an adult population, you don't worry as much as you do in pediatric population or breastfeeding or immunocompromised population. It's an excellent antimicrobial, but again, it has to be a specific population that is indicated to. But if you wanted to try and change your practice, I think you have to show that there is a validity to having a preventative component, which iodine-based products are not. It's a reactive component to a disease, whereas, let's say, hydrophobic products you could use also as a prevention.
And this question is, do you suggest betadine for peri-wound cleansing?
I do not. We know that betadine can be cytotoxic, just like silver can be cytotoxic. So I think periwound cleansing has to be used with products that are not cytotoxic. So in pediatrics, the most common thing that we use is just regular normal saline or tap water. But if you wanted to use stronger cleansers, there's safe hypochlorous acid products that are now in the market that we know are safe for all the cells and are not cytotoxic. So I would not use betadine consistently on all wounds as a cleanser.
Okay, is there any practical guideline for choosing a topical antibiotic?
Well, I think there is no set guideline that we know of, and I'm a member of International Society of Pediatric Wound Care, and one of our aims is to actually develop worldwide guidelines. But I think you just kind of have to know the literature and know the pros and the cons, and whatever you have in your armamentarium, know what's safe to use. But no, there is unfortunately no great guidelines, although many societies have put out position papers, and if you search for those, you will at least get definitely position statements, and World Union Health Society, European Society of Wound Healing do have statements that go through all the antimicrobial products and suggest when to use them and in what circumstances.
Okay, I think we're out of time for our questions, so I just wanted to let you know that we will be at the booth tonight at about 6:20, so please come by the booth, and if you have any further questions that we can help you with, we can always follow up with Dr. Boyar after. As a reminder as well, you're going to be getting a link in your chat box that you need to click on to be able to do an evaluation. Please do that. If you're not able to click on it, copy it and put it into your browser. It would be greatly appreciated. Thank you so much, Dr. Boyar. It was an amazing experience once again hearing you talk. Thank you so much.
Thank you, everybody. Enjoy your conference.
Take care.
You too.